Hello and welcome to today's Center for Healthcare Strategies webinar, made possible by the Commonwealth Fund on addressing social determinants of health through Medicaid accountable care organizations, early state efforts. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be 2 moderated question and answer sessions during today's presentation. You may submit a question online anytime by clicking the Q&A icon located in the drop-down menu of the toolbar at the top of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you will take a moment to do this. I will now turn the webinar over to Tricia McGinnis, Senior Vice President at the Center for Healthcare Strategies.
Good morning, everybody, and welcome to today's webinar. We are really excited to have so many participants and be able to share some of the early lessons around what innovative states are doing to use their ACO programs to encourage providers to address patients' social determinants of health. Today's webinar will be structured as follows. After some brief welcome and introductions, we'll do a quick overview, high level of early state efforts around using ACOs to address social determinants. And then we'll dive into our 2 featured states. We'll first learn from Minnesota about how they're using their Integrated Health Partnership Program to drive its social determinants investments, and then we'll hear from Rhode Island as well about how they are leveraging their new Accountable Entities Program to encourage providers to address social determinants. We'll have plenty of time for Q&A, both immediately following the Minnesota presentation and Rhode Island as well, and then we'll have a quick panel discussion and wrap up. Next slide. Here's a list of today's speakers. We are really excited to welcome first Pamela Reilly, Vice President of Delivery System Reform from the Commonwealth Fund. She'll offer some welcoming remarks, and then we'll turn to Rachel Matulis, Senior Program Officer at the Center for Healthcare Strategies, who will give an overview of how states are leveraging their ACO programs for social determinants. We're very happy to have with us Matt Spahn, Manager of Care Delivery and Payment Reform from Minnesota Department of Human Services. And from the state of Rhode Island, we're really happy to welcome Deborah Faulkner, President of Faulkner Consulting Group, and Deborah Morales, Senior Consulting Manager with Conduit, working with the Rhode Island Executive Office of Health and Human Services. Next slide. Next slide. So for those in our audience who may not be familiar with the Center for Healthcare Strategies, very briefly, we are a nonprofit policy center dedicated to improving the health of low-income Americans, with a particular focus on Medicaid beneficiaries, Medicaid agencies, and Medicaid health plans. We have 3 areas of priority. First is advancing delivery system and payment reform. Second is around integrating services for people with complex health needs. And third, around enhancing access to coverage and services. As part of our work with states, health plans, and providers, we deliver technical assistance and bring stakeholders together for collaborative learning. We also do dissemination of best practices using things like this webinar and issue briefs. And finally, we work closely with Medicaid leaders and Medicaid managers to enhance the leadership and capacity of their programs. Next slide, please. Just by way of context, we have been really thankful for the support of the Commonwealth Fund over the past 6 years that has enabled us to work with states through a Medicaid ACO learning collaborative. Through that learning collaborative, we have brought together states through peer-to-peer learning and one-on-one technical assistance to help them design, develop, and implement their ACO programs. To date, we've worked with 16 states, 10 of whom have launched an ACO program. And it's been incredibly interesting to see how these programs have evolved since 2011 to where we are today. There's been a tremendous amount of innovation, which you can learn more about and access on our Medicaid ACO Resource Center. The center is located on chcs.org, and it's a really practical, a set of practical resources designed to help states and others interested in Medicaid programs learn more about what ACO programs are designed to do, help folks who are interested in designing their own program, and just help folks learn a little bit more about the innovation that's going on in this exciting space. So we are really thrilled to have two of our state participants speak today and share with you the innovation that they're doing around social determinants. And with that, I'm going to hand it off to Pamela Reilly, Vice President of Delivery System Reform at the Commonwealth Fund. Pamela?
Thank you, Tricia. Hello, everyone, and thank you so much for joining today's webinar. I am Pamela Reilly, Vice President for Delivery System Reform at the Commonwealth Fund. We are a private foundation focused on creating high-performance health systems, particularly for vulnerable populations, and we've been very happy to support this important work over the past 6 years as part of our work for transforming delivery systems for high-need, high-cost, and vulnerable population groups. 6 years ago, when we began working with CHCS to support this learning collaborative, we saw an opportunity to capitalize on the promise of accountable care organizations to really transform care, particularly for society's most vulnerable and for Medicaid beneficiaries, providing specific opportunities to be able to address gaps in both care coordination as well as in some of the service delivery needs that these populations have. And with the move towards, increasingly towards value-based payment, there's greater recognition that it's not really possible to achieve these goals of improving quality, cost, and population health without being able to figure out how to address some of the social determinants of health. And so to that end, the Commonwealth Fund has supported work to not only understand what the interaction is between some of these unmet social needs and healthcare utilization and outcomes, but also to identify approaches to effectively addressing those needs and to be able to implement payment and policy options, particularly in Medicaid, that can allow for sustainable spread and scale of being able to address social needs in healthcare delivery. And over the past several years of the Medicaid ACO Learning Collaborative, it has definitely emerged as a top priority among states to be able to figure out how to address these social needs in the context of their Medicaid ACO programs in order for these programs to truly be successful and improving the health of Medicaid beneficiaries. So we're excited to share with you today some of the work that the states are doing in the context of their programs in order to truly address the comprehensive health needs of their Medicaid population. So thank you so much to CHCS for the work on the collaborative and for hosting today's webinar, and to all of you for participating.
Thanks so much, Pamela. And with that, I am going to turn it over to Rachel Matulis, Senior Program Officer at CHCS, who will give us a bird's eye view of what's happening in this exciting space. Rachel?
Great. Thanks so much, Tricia, and thanks, Pamela, for those great introductory remarks. I'm going to spend just a few minutes today setting the stage about Medicaid accountable care organizations as well as the social determinants of health before we dive into the heart of today's presentation. Part of the reason I'd like to take the time to do this is that we do have a large and really varied audience on today's webinar. We have participants from community-based organizations, we have participants from health plans, healthcare providers, Medicaid agencies, other federal, state, and local government, as well as universities. So part of what we want to do here today is lay the groundwork and make sure that we are all on the same page before we dive into the heart of today's presentation. So in terms of the agenda, what we want to cover is, first off, talking a little bit about the current Medicaid accountable care organization landscape. Second, to provide a brief overview of what we mean when we say social determinants of health. and then finally to connect those first two concepts to talk a little bit about early state efforts to address social determinants of health via their Medicaid ACO programs. So first things first, what is an accountable care organization or an ACO? An ACO can actually be deceptively difficult to define. It can look really different across states as well as across payers. However, at the highest level, ACOs are generally defined as designated entities that are held accountable for the financial and quality outcomes of a defined population. They were developed to help move the United States towards the goals of the triple aim, which I know Pamela had already referenced earlier, and the triple aim will really be a theme that's underlying all of the remarks in today's presentation. And I'm sure many, if not most of you on the call are familiar with the triple aim, but it's reflected here at the right, and it's really the goal of improving patient care experience, improving the health of populations, and reducing the per capita costs of care. So ACOs were first adopted in Medicare formally under the Affordable Care Act of 2010. However, there were efforts in the commercial market prior to that. The first Medicaid ACO program launched in Colorado in 2011 and have since become a leading payment and delivery system reform model across all payers. There are currently estimated to be over 32 million covered lives receiving care through accountable care organizations across commercial, Medicaid, and Medicare. Next slide. So how does this look when you're talking about Medicaid? This slide provides a brief overview of the current Medicaid ACO landscape. You can see here that there are currently 12 states with active statewide Medicaid ACO programs and at least 10 others that are either actively pursuing or exploring such an effort in their states. It is important to note here that this map doesn't capture any plan to provider activity that might be going on outside of a formal state effort. So if there is a Medicaid ACO that's contracting with a Medicaid managed care plan outside of a formal state effort, you wouldn't necessarily see it on this map. In part because of that caveat, it can be difficult to capture an exact number of Medicaid beneficiaries that are covered by Medicaid ACOs. However, a study conducted by Levitt Partners in 2017 estimated that there were nearly 4 million Medicaid beneficiaries receiving coverage through Medicaid ACOs as of the first quarter of 2017. So with that background, how does all of this impact health and help us drive toward the triple aim? There's growing recognition that healthcare is really just a relatively small component of what actually influences health outcomes, as can be seen in this pie chart to the right. In fact, a large host of other factors, including behavioral patterns, such as whether somebody smokes or exercises, their social circumstances, such as whether they are employed or have a house, environmental exposure, as well as, of course, genetic predisposition actually play a much larger role in health outcomes. Because most ACOs are accountable for total cost of care and quality, ACOs actually have a really strong business case to look outside of their four walls to address the social determinants of health. One of the most fascinating things I found from the article that's cited at the bottom of this slide is that zip code can actually be a better predictor of health outcomes than genetic code. Next slide. So in terms of the actual social determinants of health, I won't walk through this slide in great detail except to show that the social determinants of health really include a wide range of factors, things like income, education, employment, living environment, as well as, of course, access to the healthcare system that play a role in ultimate healthcare outcomes. So just as a couple of really basic examples to drive this point home, somebody's living conditions, such as whether they have moldy rugs, can impact their asthma outcomes. Somebody's ability to access healthy food or even any food at all could impact their ability to manage their diabetes. And whether somebody has access to stable housing or any house at all could impact the utilization of the emergency room. So the takeaway point from this slide is really just as Pamela already noted earlier in her remarks, that improving population health and achieving health equity will really require broader approaches that address social, economic, and environmental factors that influence health. So how is this playing out on the ground, and how does this relate back to Medicaid ACOs? States really have various levers at their disposal to help encourage, incentivize, and or require their Medicaid ACOs to address social determinants of health. So we've bucketed these levers into the following 5 potential opportunities, the first being the partnership or really the governance requirements that make up the Medicaid ACO program, the second being what the care management requirements are, the third being the scope of services that the ACO is required to deliver. Is the ACO just required to provide health or medical services, or is the state expecting the ACO to go beyond those kinds of traditional healthcare services? The fourth being quality metrics that are used to assess an ACO's performance. And then the fifth and final, and of course very important lever, is the financial incentives that are built into the model that impact an ACO's bottom line. So just to really drive this home and provide a few concrete examples of what some states are doing across these 5 levers, we thought we'd provide an example for each state. So in terms of partnership requirements, Colorado requires its ACO contractors to establish relationships with community-based organizations. These include organizations that address economic, social, educational, justice, recreational, and other kinds of organizations that promote the health of local communities. In terms of care management, Rhode Island requires screening for and addressing social determinants of health, and we'll get to hear a lot more directly from Rhode Island later in today's presentation about that approach. Another lever is the scope of services. Oregon requires its ACO contractors, which are referred to as coordinated care organizations or CCOs, to actually provide non-medical services to address social determinants of health, such as a member's living environment. This is something that Oregon did under an expansive 1115 waiver that allows the state to use Medicaid dollars to cover health-related supportive services such as education, job training, housing supports, and food assistance. Next, quality metrics. Massachusetts has a statewide ACO program that will be launching in March 2018, so next month. It plans to measure ACOs on selected social determinant of health-related quality measures, such as use of social service screenings. And then finally, in terms of financial incentives, there are many different tactics a state could take with respect to financial incentives, and you'll hear more about this approach from Minnesota and Rhode Island, but a particular approach we wanted to call out, again, that Massachusetts is planning to use for its program is that it will be risk-adjusting ACO's payment rates as well as its cost targets based on selected social determinant measures, including stability of housing, as well as a neighborhood stress score that it developed based on census data. So before we turn the presentation over, I just wanted to point you all to some sort of new and notable resources on the topic, some of which were put together by CHCS. Others were funded by the Commonwealth Fund around how to better address social determinants of health through Medicaid managed care plans. So we invite you all to check these out if you're interested in learning more. With that, I will go ahead and turn it over to Matthew Spahn to talk a little bit more about Minnesota's approach in this topic.
All right, thank you so much, Rachel. I hope everybody can hear me and I'm loud enough. I'll assume that I am. So thank you guys so much for inviting me to talk about our the evolution of our IHP program into 2.0 and the integration of these social determinants of health into that model. What I wanted to start with is just a little bit of background on the Integrated Health Partnership Program here in Minnesota, because I think that obviously sets the context for some of our more recent changes. But similar to probably a lot of different ACOs across the country, our initial model, which started in 2013, was really largely based on something similar to the CMS's Shared Savings Program, where some of our participants had upside-only models, and others had, eventually both upside and downside reciprocal risk types of arrangement. In developing that initial integrated health partnership model, we really overtly decided that we wanted to build a lot of flexibility. We wanted to make sure that we were focusing more on the what we wanted, the outcomes, which of course were driven by the triple aim, as Rachel mentioned, but not necessarily prescribing specific things that we wanted our health systems or participants to do to reach those outcomes. But all of that kind of built on a strong chassis or a strong base of accountability for both the quality of care and the cost and utilization of that care that is delivered. Through this flexibility, as I said, we started in 2013. We had 6 IHPs that were part of that, covering maybe 10% of our Medicaid population. And as of this year, we have 24 IHPs, and it covers about half of our population, or 460,000, 470,000. I think the most recent attribution, actually, that we just did, it says 475, about 475,000 beneficiaries. And part of because we've had this model in place for a couple of years, it was really important for us to continue to examine, evaluate the successes, the challenges, and we knew sort of that we would continue to develop this model. And so that really allowed us to launch what we're very creatively calling the IHP 2.0 model that started just about a month and a half ago. And so that's going to be really the focus of my conversation with you guys today. Oh, and I should say that under the 2.0 model, we have 13 IHPs that are participating, and we still have 11 of our IHPs that are under a legacy model. So just kind of additional contextual background. So what I wanted to highlight here is that we did have some pretty good, decent success in the first 4 years of our legacy integrated health partnership program. You can see that we did have, pretty good savings, $213 million across the participants, reaching nearly half of our Medicaid population. A couple of things when we look at sort of what was driving some of these were that really care was being delivered in the better location by the right providers. So our emergency room visits went down, hospital stays went down, and all of this was really positive, although not necessarily sufficient to continue to move in the right direction. What it did allow us, though, is those early successes really did let us have some social capital and have some backing in making some of the tweaks that we wanted to make in our program. So let me talk a little bit about some of the core concepts within the Integrated Health Partnership Program that we have. One of the first things is that it does cut across both our Medicaid population and what we call Minnesota Care here in Minnesota. This is our basic health plan in Minnesota. And it also cuts across both our fee-for-service population and our managed care population. In Minnesota, about 85% of our Medicaid beneficiaries receive their coverage through a managed care entity. So it was really important that we were across all of that. As I mentioned, we did want to have a lot of built-in flexibility, but our model is still primary care-centric. We have a defined core set of services that are included, and it's very broad. It's nearly all Medicaid-covered services that are included in our core set for total cost of care and accountability. We added very recently, and I'll talk a little bit about this population-based payment to the model. And one of the things that to really highlight is because, again, we wanted to have that flexibility, we wanted to allow new entities to enter into our Integrated Health Partnership program. We created 2 different tracks. Track 1 has no shared risk, so they have no upside or downside potential, but they do receive this population-based payment, which is used to support innovative care delivery, care coordination. It can also be used for some of the infrastructure, sort of upfront infrastructure costs, because one of our findings was that developing ACO models, health systems jumping into the ACO arena, sometimes takes a lot of capital for investment, and not every system had that. We also have this track 2, which is a track that has to have both upside and downside. So we made an overt choice in our 2.0 model that if you wanted to have upside potential shared savings, you had to take potential downside losses as well. And so they have that total cost of care shared risk as well as the population-based payment that can help them in some of their care coordination costs, et cetera. Another sort of really important aspect of our model from the beginning was that DHS needed to act as a facilitative partner. We didn't want to just simply establish accountability, kind of back off and say, hey, hopefully you're successful. And we really always saw ourselves as a partner with our health systems because they're the ones who are really directly impacting our beneficiaries. And I'll talk a little bit about what we're doing in 2.0, but one of the big ways for us is through robust data, robust reports, and technical assistance types of things. So in the 2.0 model, what I would really highlight as being some of the critical enhancements, moving away from what really looked very much like a shared, MSSP type of a model to something a little different, is that we brought in these social determinants of health, that we really saw this as a great opportunity for us to widen the focus of health and care for our beneficiaries beyond just the simple medical model. And that we really saw through enhanced partnerships, something we call accountable care partnerships, this population-based payment that can be used in a flexible way and covers the entire population of an IHP, as well as adding some additional metrics into the mix that we didn't necessarily have before. All of this was really leading, and one of the key things that we sort of wanted to drive all of this thinking was the sustainability of the integrated health partnership and the sustainability of the different partnerships that an IHP may have with social service organizations, community-based organizations in serving our beneficiaries. So this slide here provides a little bit of a framework that I like to use when I'm thinking about how our IHP model is sort of operates or framed up. Because, like I think all state agencies, we really don't necessarily play a direct role in providing services to our beneficiaries. We have a few levers that are kind of once removed. And the way I really look at this is that we can either require certain activities by our health systems that are participating in an ACO, sort of the regulatory side, or the you must be this tall to ride this ride type of requirements. Or we can look at trying to create the right incentives, and this can be either direct or indirect. For example, in an ACO model, obviously if you save money, you may be able to get some shared savings. That's a nice incentive. The third prong is, again, as I mentioned in a previous slide, is what can we do to help? What is that facilitative and support role that we as an agency here in Minnesota can play in enhancing the ability for our IHPs to serve our beneficiaries? And so I'm going to use this framework to kind of walk through how we've integrated these social determinants and social risk factors into our model. So the first, as I mentioned, is sort of that regulatory or requirement side. And we do require an application process. We use a request for proposals type of method for IHPs or for health systems to jump into the IHP program. And that application process really, we ask a number of different questions and require certain things to be in place. The first is that they do need some sort of certification, generally either PCMH, the primary care medical home type of certification, what we call in Minnesota healthcare homes, an ACO certification, prior involvement in an ACO model at Medicare or Medicaid level. If they don't have those pieces, they can still apply, but there's a lot more paperwork, if you will, to ensure that they have certain things like care coordination, infrastructure in place, health record system that can support this type of activity, different workflows, a lot of that stuff that the certification sort of already gets them through that window. The second piece is the demonstrated partnerships, and these in the application process can be either formal or informal. And we want to see these partnerships with different community-based organizations, social service agencies in their region, maybe public health, counties, or really other organizations that are focused on more of a population health and social determinant type of activities. As I said, these can be both formal or informal, and we do want the IHPs to really think about who they're partnering with or who they can partner with during even the application process. And the last piece is that they're meaningfully engaging patients and families as a partner in the care they receive. And this really, what we'd like to see is involvement in some decision-making bodies of some sort, or advisory boards, this can be in some of their, maybe their quality improvement board, or an IHP executive board. We have a couple that include patient advocates and patient spokespeople, et cetera. But what we don't do is necessarily say exactly how each of the IHPs have to meet these requirements. The nature of those partnerships, kind of what they describe within their application, gives us information that we then use in developing the contract and developing the terms of that agreement, which I'll talk about in a second. So the second sort of lever that we have within the framework I like to use is the incentives that we have. And I really see sort of two incentives that we can use to leverage those social determinants of health and get the IHPs to focus on that as an aspect of what their model looks like. And the first really is tied to the population-based payment. As I mentioned, this is a population-wide payment that can be used for care coordination activities, infrastructure, et cetera. But it needs to be, and it is overtly tied to health equity metrics, along with clinical and utilization metrics, sort of your more traditional preventable events type of metrics, or diabetes care, et cetera, et cetera. And those specific sort of suite of measures are tied to specific identified interventions that are largely idiosyncratic to the target population that the IHP serves. So an IHP in rural Minnesota may have a very different target population or population of patients that they serve than somebody in the metro area. And so we wanted to have that sort of suite of metrics really focus on what made sense for their population. It's a pretty heavy lift, but it's been a really important and enlightening activity in developing the contract terms for these IHPs. The second area is under the risk arrangement in terms. As I mentioned, a Track 2 IHP can enter into a risk arrangement where there's potential shared savings as well as potential shared loss. Our assumption is that any one of the Track 2s will have reciprocal, meaning the amount that they can potentially gain equals the amount that they can potentially lose in our arrangement. However, if they can establish that they have one of these, what we're calling accountable care partnerships, because we are a state agency and we love our acronyms, or ACPs, that they can mitigate their risk in that risk arrangement and get something closer to a 2-to-1. So they can maybe, if they want to gain on the first 10% of shared savings, they only have to be willing to lose on the first 5% of shared losses, for example. And in evaluating these accountable care partnerships and to determine whether they're meaningful enough, a couple of really important key pieces come up for us. The first is that they need to be formal. If you remember when I was mentioning in the application process that we do allow you to have the IHPs to have informal partnerships in place. However, that won't be sufficient for them to get the sort of non-reciprocal risk that we want to see in place. So that formality can be through a contract, an MOU, some other sort of written instrument where both parties are agreeing to specific terms. The other piece is that the partnership has to lead to both the sustainability of that partnership as well as the partner. One of the things that we really wanted to avoid doing is a lot of social service organizations, community-based organizations, the way they're funded doesn't necessarily attach directly to the number of people that are maybe coming through their front door. And so by trying to encourage a medical system that's based on funding that's sort of per person to sort of push their population to be served more effectively by these social service organizations, you could actually hinder the community-based organization or social service organization in their ability to serve their clients. And so we wanted to make sure that that was part of the agreement, that there's additional revenue or there's some additional in-kind, that there's something that's going towards sustainability of the actual partner in a truly meaningful way. So the third lever is this sort of what can we do for the IHPs? What ways can we enhance our integrated health partnership models to be successful in what they do in driving towards, addressing social risk factors, addressing social determinants of health? And again, this comes in sort of two different ways. The first is that our population-based payment is based on a combination, sort of the amount of that payment is based on the clinical or medical risk of the attributed population for the integrated health partnership, as well as the social risk factors or risk kind of quotient that we determine for that population that the IHP serves. This has probably been where there's been the most challenge and the most work put into kind of creating an initial social risk factor or adjustment on that. But, and I'll talk a little bit about the specific areas that we're able to look at right now. But the gist of this sort of social risk adjustment is that we first start with that ACG. We use Johns Hopkins ACG risk adjuster to come up with that sort of core risk. Then we look at the additional predictiveness that each of the different social risk factors that we can look at based on individual level data, what it suggests for healthcare outcomes or total cost of care for that particular patient. And where we see patients with these particular risk factors that increase the overall sort of expected cost for that patient or poor outcomes, we kind of move those individual patients up the risk ladder so that they receive or sort of worth a larger per member per month for the population-based payment. And we kind of aggregate all of that information at the individual level to come up with a population level per member per month for the population-based payment. And I should mention the population-based payment is paid on a quarterly basis, and it is at PMPM amount. The second piece that we use that's sort of the facilitative is that we provide data both at the aggregate level or demographic level of the population the IHP is serving, highlighting how many in their population, for example, maybe have housing instability. And I have listed here on the slide all of those different pieces. SMI, housing instability, prior incarceration at an aggregate level, and then where possible, where it's sort of legal and available and makes sense for us to provide at the individual level, we will. So for example, the housing instability metric is one that we can provide, which was developed in collaboration with one of our IHPs. So I think since I have just a couple more minutes in my planned timing, maybe I'll talk a little bit more on the how we developed or looked at those particular metrics in the social risk adjustment that we have for our population-based payment. We started with some in-house research to identify which were the factors that had the most impact on disease prevalence, poor health outcomes, or cost. This was research that was conducted by our medical director's office and was funded in part through some grants as well as some legislative funding, which was intended to identify how we might modify Medicaid payments based on these factors. So we took some of this research and we really, and I will say that research was based on existing research sort of nationally by other different researchers, as well as, and this is sort of a key piece to this, the data availability that we actually had. There's certain factors that we just don't have very well at the individual level. So an example of this would be food insecurity. We can get at that through a sort of geographic level, but we didn't feel that we could really identify something at an individual level, and so that was one that ended up falling out of our model. So we ended up looking at these individual level factors: substance use, SMI, housing instability, prior incarceration, and deep poverty, or for the pediatric population, a parent with one of those, as well as child protection involvement, and looked at this sort of, like I said, that impact on their cost outcomes. And that was done through some logarithmic applications and some things that are sort of outside of my expertise, I should admit. And then we worked with our actuary to identify, again, what's the sort of predictive value of those additional factors in addition to the clinical factors that are already present within our population. We looked at a few other factors, like I said, that kind of popped out of the model. The food insecurity was one of those. Deep poverty is included, but it's a very small factor here. Yeah, so I think that gives kind of a general idea of how we looked at that. If people want more, we can maybe talk more in detail on the questions if people want to go into that. So what I wanted to end on, though, is we really see this social determinant factors, the social risk pieces, and all of the different components that we've integrated into the IHP 2.0 model as the beginning and not the end. We fully anticipate that in the next couple of years, we're going to continue to refine our social risk factors, try to identify more information that we can have at the individual level. We're going to continue to monitor, evaluate the arrangements, the accountable care partnerships, the specific interventions that are tied to the population-based payment to see how we can maybe continue to push the envelope, as well as are these the right ones to look at, and really, again, evaluate the overall effectiveness of this in making our beneficiaries healthier overall. So I think with that, I'll stop and see if there's some specific questions people have.
That was great. Thank you so much, Matt. I just want to remind the attendees that we're going to take some questions specific for Minnesota at this time. And so if you'd like to submit a question, you can do so online anytime by clicking the Q&A icon located at the drop-down menu at the top of your toolbar. So with that, we have already had a few questions come in for you, Matt. We've had a few specifically related to data, so I'm going to combine a couple of questions that came in into one for you. So this question is, how are you able to have data related to social determinants of health, such as housing instability, prior incarceration, et cetera? And then are the data and reports that you're preparing for the IHPs shared with your community partners?
Sure. So on the first question, a lot of our information comes from our enrollment and eligibility system. So the poverty metric, the housing instability, for example, is one that we use our eligibility enrollment system, and the addresses that we have on file, and we look for, are those addresses for known homeless shelters, or are they, changing quite a bit? And there's a couple of other pieces that we do. So we do some analysis to identify, hey, this person is likely somebody who's encountering housing instability. The serious mental illness and substance use disorder, again, is driven by our claims data as well. Prior incarceration was one. We had to work with our Department of Justice to get the prison data, and we're actually talking with them right now to identify if there's a way for us to get county jail information from our Department of Justice. Because we've heard from, kind of at least anecdotally, that county jail imprisonment is more a factor that shows up more often in a number of our populations, but it may have a greater impact than sort of prison incarceration, so to speak. So that's how we're getting at those pieces of information. We're continuing to look at what else we can do, how else we can grab other bits of information. On the food insecurity, we're working with, for example, Second Harvest, which is like a food bank, a large food bank here in Minnesota. As far as the data that we provide to the IHPs, like I said, right now it's an aggregate, and we're looking outside of a couple of the individual factors. We're still evaluating which of these can we legally share. For example, child protection involvement is not a factor that we can share at an individual level. So we're sort of looking at, are there ways that we can provide this, some other kind of a flag or analysis? We don't require the IHPs to share this information with their specific partners, in part because it's generally happening. And so we didn't feel that we needed necessarily to put a requirement for that, but that's the large way that these partnerships are able to be operational, is in sharing some of this aggregate information that they do have.
Great. Thanks so much, Matt. And I think we'll do one other question at this time before we turn to Rhode Island. And we're getting a lot of questions around your health equity metrics. So could you maybe just talk a little bit more about those and potentially provide an example or two?
Sure. So the health equity metric is one that, again, there's so many aspects of this that we're kind of developing as we go and know that they're going to continue to hopefully evolve and be better. So as I mentioned, in our equity measures that we're looking at, they're tied specifically to kind of idiosyncratic interventions that our IHPs are doing based on their target populations, based on some of the specific issues that their community is maybe experiencing. So, for example, we have in Minnesota, as I think a lot of states do, an opioid epidemic. So that's one of the interventions that we're we're kind of looking at is this substance use disorder driven by opioid addiction. And we do have a couple of our IHPs have chosen that some interventions around wraparound services tied to substance use disorders and opioid addiction. And so our equity measures right now, I would really describe as being in many ways kind of more process-oriented, because we're still sort of looking at how do we get to some outcomes in this equity space. So for example, in that one, looking at the number of patients that are referred to behavioral health consultations and substance use consultants, number of those patients that are referred that actually close the loop or actually get services from the maybe an addiction specialist or other addiction services, number of patients that are assigned a care plan that is tied to some of the health outcomes that are related to that type of an addiction. So that sort of gives you a general idea. I'm looking for a couple of other good. So another one that we have, one of our systems has tied their, they have a lot of food instability and insecurity within their population. And so they have a partnership with Second Harvest, who I mentioned earlier, which is a food bank but really does a lot more outreach, and they do sort of a food prescription type of model that's specific for people that are maybe food insecure and have diabetes or other chronic conditions. That food is a really critical part of managing their health. And so this system with this particular partnership is their metrics are looking at things like number of people who receive food supports and the food, so SNAP services and others that didn't have it previously, number of people that are actually receiving these food boxes from Second Harvest, screening and percentage of patients that are then ultimately referred to the program, those types of things. So again, on that health equity side, I would describe it as our sort of first thrust into this is looking at, not too surprisingly, more of what I would describe as process-oriented types of activities.
That's great. Thanks so much, Matt. That was really helpful, illustrative examples. We really appreciate it. And just to remind folks, too, at the end, we will be circling back for a larger panel discussion, so we can take some additional questions from Minnesota at that time. So I'd like to now turn it to Deborah Morales and Deborah Faulkner from Rhode Island to talk a little bit more about their approach in terms of how things are playing out for their Medicaid accountable entities. Deborah and Deborah?
Sure. Hi, everyone. This is Deb Faulkner, and I just wanted to start first by saying thank you. Our work on ACOs has really been critically supported by the work that CHDS has done for us, and in particular the Learning Collaborative that we were able to participate in. I don't think we would have gotten half as far as we had without that help, so first thank you. And I also would acknowledge a thank you to Minnesota, because having you guys already on your 2.0 made it a lot easier for us to learn from the history and the experiences you had with your original model. We learned both from your model and from your analytics. It's always impressive to see what you guys put out, so thank you. When I look at what we have done here in Rhode Island, we were starting from a place where we had a fairly well-functioning or a very well-functioning managed care base. We had really top NCQA rankings, we had really high quality, we had excellent access. And what we were trying to do was we knew we needed to do more, in particular to address the high and rising risk populations, because we knew that although, you know, our quality and costs were really going well, we hadn't really tackled that top 6% of users, and that our managed care structure wasn't really set up to tackle it. Those were populations, you know, like Rachel and Pam said in the beginning, most of whom have a combination of complex needs that integrate physical, behavioral, and social determinants, and that it's very hard to address at a sort of higher level through your managed care structure, but we really needed to change the way care was delivered at the provider level. And in doing that, not just build programs, but also better align financial incentives, because although we had managed care plans that were capitated and at risk in managing a population, our provider system was still very much fee-for-service. And so we used to call it, we sometimes call it managed care and drag, in that we have managed care, but we have fee-for-service payments underneath it, and until and unless we change the financial incentives so that not just the state and not just the managed care players, but also the providers, we all benefit when we accomplish things that reduce costs and increase quality for complex populations. And that's kind of the impetus for our ACO program, where we said, all right, switch to the next slide. What did we want to do with our ACO program? We wanted to top down, we wanted to change the payment model. We wanted to build financial incentives that move away from fee-for-service, that build population-based focus on a population rather than on a service. And we wanted to both top-down change the payment model and bottom-up change the way care was delivered. So deliver coordinated care that wasn't just within one piece of the silo, but actually coordinate primary care, behavioral health, and social determinants, and build that capacity and enable that capacity for our providers. So that was not, you know, it's motherhood and apple pie, all that stuff, but it's hard. It requires a sustained investment. It requires a commitment. It requires changing payment models and a lot of changes in the way that we deliver services. And so I say that because then if you look at our timeline, you see on the next page, you see that depending on how you look at this or depending on the day, I would say this is ridiculously fast or what took us so long. We started in June of 2015 with our governor-led Reinventing Medicaid initiative. We put in place a pilot very quickly by January of 2016. What I'm called here phase 0, a pilot that ended up having.
I'm so sorry. Yeah. Before you go too much further, we're having some comments from the audience. They're having a little bit of trouble hearing you. If you could just get a little bit closer to your telephone, I think that would be helpful.
Sure. I'm now almost hugging it. So
thank you very much.
So let me know if I need to do better. But so from a timeline perspective, we started in June of 2015. We started with a pilot. The pilot, we thought, we didn't know how many ACOs would, or what we call our accountable entities, would participate. We ended up with 5 AEs over the course of 2016 that by now have about half of our Medicaid managed care membership. So we really have grown quite a bit. And we're moving towards our next phase, our phase 1, where we're actually trying to help invest in the infrastructure that the accountable entities need to support the change in their payment model and the infrastructure they have to build. I think Minnesota said as well, you realize that some of these entities can't make the changes without enabling that investment. Just to back up and say specifically, as I said before, we built on our managed care platform. And I think when we started this project, we looked around at a lot of other models. We learned a lot from Minnesota. We learned from Colorado. We looked at New York. And what you learn when you look at ACO models out there is that when you've seen one ACO, you've seen one ACO, because there's no one model of how they're structured or how the state should design the program. And so what you really do hear from everyone is start with what you do well and build on what you've got. And so that's what we did with our program, in that we encouraged and established a program within our managed care infrastructure and encouraged them to build additional capacity at the provider level to serve high-risk complex populations. So what does that mean, and what is this program, and how does it work? Well, we think of it as having sort of this three-legged stool in our approach. As I said before, bottom up, you've got to build capacity and infrastructure. That's number one, and that's our certification standards. And what we said there is you've got to define expectations. You've got to say what you want those provider capabilities to be. So if we want integration of physical and behavioral and social determinants, we have to set some standards of what we want these entities to look like. Otherwise, everyone's going to raise their hand and say, "Oh, look at me, I'm an AE. Nope, I'm an AE too. Let me I don't need to change anything. And so we did have to look at industry experts out there and look across the board and say, well, what does a good ACO, what does a good ACO look like, and define some expectations. Second, that's bottom up. We had to encourage the development of some capacity. We then top down, we had to change the payment model. We have to move from fee-based models and fee-for-service models towards alternative payment models that really hold providers accountable for a population. We established a total cost of care model. Our initial phase is for shared savings with an expectation and a very clear expectation over time of moving towards risk. And that combination is hard to pull off without the third leg, which is incentives. And that is, we can say we've got standards you've got to meet and you've got to switch to this new payment model, but without some investment in building the capacity to both change your payment model and change your delivery system, providers can't get there. And so we're lucky enough to work with CMS to establish an incentive program that really can be used to enable the building of the capacity that those providers need to do. And, the interesting part of that is, and we'll talk more about this, is sort of, well, what exactly are we making them do? And what are we kind of encouraging and letting them decide to do? So how prescriptive are we in both the incentives and the funding that we're providing and in the certification standards that we've established? And I would turn to the next slide to show it's really interesting to try to figure out what level of prescriptiveness to establish, especially in a model where we're what we call affectionately the grandparent, where the state on top of an MCO on top of an accountable entity. And we don't always know what the answers are. We don't know exactly, I would say, how to address some of these social determinants. We do know that they matter, and we know that if we don't address social determinants, we can't really address the most complex populations, but we don't know which intervention will work. And so what we tried to do with our certification standards was to establish some baselines of what we expect, what the capabilities we wanted of the providers, but not how to do it. And that was an interesting balancing act for us. And in part driven by what we kept reminding ourselves of trying to be data-driven, to say if there isn't evidence that this is the way you have to do it, then we have to give the providers flexibility to do it a variety of different ways. In terms of the incentive funds, and I think this is where we're very lucky to have, as I said before, we had to change we had to establish requirements or certification standards for these entities, and we had to change the payment model, but in order to encourage that investment, we had to provide some incentives for them to change the way they operate and give them some infrastructure funding to enable a new model of care. And so that's what our IHP program is it's a partnership with CMS that enabled us to build partnerships with our institutions of higher education or our universities, where that expenditures on workforce is now a matchable expenditure, which frees up resources for us to invest in our accountable entities program. It's a short-term investment. It's a 5-year program, and that investment over time needs to be replaced by shared savings. So it's truly got a sustainability model kind of built in that we can invest for a while in building partnerships with social determinants and building enhanced primary care capacity and building new care coordination models, but at the end of the day, that investment has to be replaced by shared savings and ultimately by shared risk. In terms of our progress to date, I just quickly to state for us, 142,000 folks in our pilot program may not seem like a lot, but Little Rhode Island, that's half of us. And so we've had enormous growth, and it just demonstrates both the interest, frankly, the readiness of some providers to say, yeah, I do want to move away from fee-for-service. I do think that we all sort of agree that in order to get to that next phase of caring for these complex populations, we've got to move to a new model. And so we have made progress in terms of engaging providers and getting folks into our pilot program, and we have had some successes in terms of financial performance. This is our very first year under the pilot. The challenges are, the list could be forever, but the things that I wanted to bring up specifically as they relate to social determinants. First is that this is really, as I said before, it's a three-way relationship. We've got a partnership with the MCOs, and the MCOs have a partnership with the AEs. So our job as grandparents is to establish guardrails for the program and establish incentives and to enable the partnership between the MCO and the AE to work and make sure they do what we want them to do, make sure they accomplish the outcomes. We try as little as possible to tell them what to do, but rather tell them where we want them, what we want to accomplish. And so that gets to sort of really hard questions around within the social determinant sphere where we always get is, should we be investing in one specific program for example, for substance abuse that we know in the community is well respected and works well? Should we tell our AEs that they have to build or that they have to buy those capabilities, or should we enable, or can we allow them to build it in-house? Those are questions that we are constantly revisiting and making sure that we, it's evidence-based decisions, that where we give some flexibility and some rules, and when we do see differences, we try to measure and see where they're different. One place where we have been particularly prescriptive is on the measurement of the building the capacity to screen, refer, and follow up on social determinants. And that's because if we can't say what programs people are even accessing, if we can't quantify, if we can't count people and their use of different services, we'll never get to a clear business case of where to invest. And so at a minimum, what we have to build is better information about what are the needs that people are experiencing and how and where are they accessing care and what's working and what's not. And so that's where we have put an extra emphasis and that's where we've leaned towards standardization as opposed to flexibility. I also would say that it's a CMS partnership that both puts bounds on what we're doing and limits what we can invest in. And those are very appropriate and necessary guardrails. They can slow you down, but they make us careful. And then the last challenge that I'd mention is one that has its own slide around sustainability. All of us want to believe in the value of investing in capacities and capabilities to serve populations with social needs. The challenge is making sure that those investments we make are sustainable, because we can't build infrastructure that 5 years from now we can't then pay for. And so what we've been really trying to do is create this model where we can invest initially in some capabilities and building capabilities that ultimately, if they work, the AEs should accomplish some savings and retain those savings over time that actually enable them to continue to invest. And that's what we've been really working a lot on, is making sure we have a financial model that doesn't require us to keep paying for services, but rather allows the accountable entities to invest in those services. And so if I'm a community partner out there, I've got to make sure that I've got a business model that works for that accountable entity, that I can demonstrate that I'm adding value for them, because ultimately it's investment they're making in my capacity, in my substance abuse program, in my whatever housing capacity. That's what we're looking for those accountable entities to do and for those providers to demonstrate. So with that as a background, I'm going to turn it over to Debbie to give a little bit more specifics on how we've built and into those 3 legs of our stool, that certification, that those payment changes and those incentives. Social determinants are built into each level, each of those legs as we go.
Thank you. So very quickly, because I think Deb speaks to much of this already, but as we looked at how best to design an approach that would move us forward in accomplishing our goal of advancing the integration of social determinants of health into an individual's total cost of care, we thought about and we continue to think about what are the enhanced capabilities needed. So I'm not going to read the slide to you, but things like screening, referral management, the ability to close that loop from a follow-up and outcome perspective, data collection, tracking, reporting, what kind of capacity is needed? Are we pushing our AEs to build more in-house capacity, or are we encouraging them to leverage what exists outside of their four walls? Which led us to a number of key considerations. And so during this process, I think, we've looked at what was happening here in Rhode Island in terms of social determinants of health. We looked at what was going on in other states and other accountable care organization programs throughout the country with help from CHCS. Deb mentioned we have a pilot. That pilot provided an opportunity to really understand what was happening currently with our AEs and where they were. We did a brief assessment and informal of our AEs and plans to get some additional insight into their capacity now, what they were striving to do in the future, what their vision was from integration of the social determinant of health perspective and their strategy moving forward. We tried, but certainly could do much better from a stakeholder perspective to continue to get feedback. And I think recognize quickly that every AE is every ACO is at a different point in terms of social determinants of health and their ability to screen, refer, collect information, et cetera. And again, we continue to think about how much flexibility we're allowing versus standardizing, building or buying, and importantly, thinking about how we, with the incentive fund opportunity, are able to get those that funding to community partners, and where would we start and what that would look like. Next slide, please. So to build upon the approach that Deb already mentioned of the three-legged stool, from a certification perspective, we included requirements, if you will, around having to have a certain level of capacity and ability to provide services. So things like, does an AE have a method of arranging supports in high-stress areas like housing or food insecurity? How is an AE mitigating the impact of critical areas of social needs, and so forth? We put priority in certain areas or social determinant of health domains. And then from a screening and referral management process, we outlined a level of criteria or that we would be looking for our AEs to use when thinking about screening tools. So is the tool concise and easily integrated into a clinical or care management setting? Is it culturally and linguistically appropriate for all beneficiaries? Is it actionable? Is it evidence-based and adaptable, and so forth? Again, and I'm going to get into this in more detail in the next few slides, but from a payment perspective, we included a social determinant of health measure in our quality scorecard or common measure slate as part of the total cost of care methodology, and put in a requirement around there being a collective partnership and strategy between the MCO and the AE in that regard. And then from an incentive standpoint, we included some of the incentive money, 10%, to be used for funding of establishing a partnership between an AE and a community-based organization. Next slide, please. So from a certification standpoint, we've established certification requirements for our AEs to demonstrate capacity and capabilities in addressing social determinants of health. Priority domains are required as part of the certification standards in relation to housing and food insecurity and domestic violence. Capacity, the AE must demonstrate clear evidence of capacity in terms of defining relationships with community-based organizations, their in-house social support, and the type of agreements or arrangements they have with outside community-based organizations, and then the type of screening and referral management process that they have or plan to have in place to be able to arrange for supports in the areas outlined below, from housing, food security, safety and violence, basic needs, utilities, employment, etc. Next slide, please. From a payment perspective, again, we included a quality measure as part of our quality scorecard multiplier that's specific to the social determinants of health. It's not a perfect measure. It's a very basic process measure that you can see there. Percentage of attributed patients who were screened for social determinants of health using an approved screening tool where the AE has documented the screening and results. This is a pay-for-reporting metric in the first year. And again, it's a starting point. I think that it provides an opportunity for the state, for the AEs, for the plans to learn from the experience, to implement different tools, try different ways in terms of data collection. It's really meant to be a true type of quality improvement exercise where we can learn from each other and hopefully within a year, have a more informed or at least to a more informed, robust measure, and that we've had some level of best practice and lessons learned through the experience. And I would just, because I don't know that I'll get to all of this at the end, but just to say that we're not doing this in isolation. There is a statewide effort in Rhode Island led by the State Innovation Model Project, along with United Way of Rhode Island and our two big hospital systems, that is also kind of convening an array of stakeholders and tackling the issue of starting with building a resource directory and what that would look like. Again, we learned really quickly that between the state agencies and the number of community-based organizations, small and large, people have implemented and have built their own tools, have their own methods, and so I think that's the goal over the long term, is that we're able to find a place where we can not rebuild, but use what's out there and leverage that all the while coming to a place where we're centralizing where possible. In terms of incentives, next slide, please. Again, we have placed a requirement as part of our performance incentive that 10% of the incentive pool that an AE would receive as part of their performance is tied to the execution of an agreement with a community-based organization to address social determinants of health, behavioral health, or substance abuse. The incentive funds would be, again, provided to a partner who is providing community-based social support services and should minimally include 3 core components. Protocols that enable the identification, again, going back to the screening process, protocols for the referral of the attributed member. So again, going back to how are you referring someone, how are you closing that loop and managing the care of that person and knowing that the person actually receives the service they're in need of. and a reporting requirement in terms of how all of that information is being collected and tracked.
And this is Deb Faulkner. I'm just going to add, so when we looked at our certification standards and we said, all right, these providers have to demonstrate that they have capacity to serve the social needs of the population. And they all said, many of them said, well, gee, we've got that. Don't worry, I've got that. And so we said, fine, some of this you can have in your existing capacity, and some of, but it can't be the case that you have all of that in your existing capacity, and or that you can build all of that well. And so we did want to make sure there was some investment in existing capacity in the community, but we're not going to tell you which thing or where you have to invest it, but there must be some of these social determinant capacities that you don't have, that you're not going to build, that you're going to buy from our community partners. And that's what this 10% is tied to, is as they get their incentive dollars, 10% of it has to go out the door to a community partner. And that community partnership has to include a method for us to track and monitor and understand where are people getting care, how is the referral happening, and is that referral, who is it going to and where, and is that referral actually getting executed. And so that's like for us the starting point is we have to count. I always think it's interesting. There's so much evidence out there of the need for social determinants. There's not great evidence around what to invest in. And so we're just trying to build an infrastructure that enables us to understand over time, what are people doing? Where are they getting that care, and what's working? Because until and unless we can do that, we can't, we'll never make the business case here in Rhode Island for further investments in social determinants if we can't do that counting well.
Thank you, Deb. And if you go to the next slide, it's the last slide. It's just a link to our website where you can find more information about the Accountable Entity Program. And certainly you can reach out to either Deb Faulkner or myself if there are questions that we can be of assistance in addressing that we don't get to today. There's a lot of detail behind all of this that we didn't speak to, so I guess at this point we'd be ready for any questions that folks may have.
Great, thank you so much. We do have a lot of questions that have come in, many of which were around your process for reviewing screening tools. We understand that you don't require a specific tool, but there were questions around how you as Rhode Island are reviewing and approving tools, and if you could provide any examples of the tools that are being used.
I wish I could. More to come is the answer. Those requirements were just put in, and we are going to be reviewing what people's submissions. They come in February 15th. I think that's tomorrow. And so as part of that, we will be seeing what people are proposing, but I haven't seen it yet. And so, the dimensions of how we're going to assess it is on, the kinds of, dimensions Debbie was talking about of, how well it, I don't have them in front of me, but, reasonable dimensions of are these good, but not, but we don't have any specific tool in mind.
I would just add that what we outlined, and I think it's either in the certification standards or even in the description on our website of the social determinant of health measure, that we just wanted to lay a foundation of some just basic minimal type of criteria that a tool would have to be, like I had mentioned earlier, being culturally and linguistically appropriate. But to be honest, I certainly don't believe we think that we're the subject matter experts on this, as well as this is evolving and we're learning too. But again, we just wanted to lay a foundation that we could then learn from moving forward. So definitely more to come. And we know that different tools are being used that are known nationally, and others that are more
right. And all of our providers were at a different place. Some had one and said, don't you dare try to standardize it, and some were nowhere near. And so we really got a lot of pushback on trying to say, well, maybe we should have one, and we didn't feel we were ready to have one. So we said, all right, just show us what you have, and we'll build on what you've got. We'll start with that this year.
And I would just say in a nutshell, what we've asked is for our plans, AE stakeholders to, it's really a collaborative process that we want everyone to commit to moving forward as we develop and enhance our strategies around social service and social determinant of health interventions, data sharing, et cetera.
Great, thank you so much. And I know there's still a lot to come in Rhode Island, so we appreciate it. And we did just at CHCS want to put a little plug in for a paper that we recently released around screening for social determinants of health in populations with complex needs. It's a paper focused on implementation considerations. So if folks are interested in learning a little bit more about screening tools, that tool is available on our website. I think at this time, because we have gotten so many great questions that I think would actually be great for both Rhode Island and Minnesota, that we could go ahead and open it up to some of the more general questions that came in. So one of the ones that we received, which I thought was interesting, and maybe Matt, we'll start with you just because I know things in Minnesota are a little bit further along, but are you seeing any support for or any active development of what was referred to in the question as novel partnerships? So things like partnerships between IHPs and law enforcement, fire departments, community paramedics, et cetera.
Sure, I think that's a great question. We haven't seen too much with IHPs and law enforcement or fire departments. I know there have been some conversations, but I wouldn't necessarily say that we've seen them develop in a more formal way, in particular around certain things like the opioid crisis, where I think that drives and does involve law enforcement a little more intimately, as well as sort of follow-ups post-incarceration and that type of thing. We haven't necessarily seen in that area. On the community paramedics, we do have a couple of our IHPs. North Memorial is probably a really good example of one that has been working in that space for quite a while and continue to kind of enhance their community partner or their community paramedics activities and partnerships around that. And so that area we certainly have seen some really interesting work in helping to work with people once they're in the community, make sure that their medication management and those types of things are being done effectively, and keeping them out of the hospital is sort of typically one of the primary goals of that type of an arrangement. I suspect that in the next couple of years we'll probably see more of a novel partnership on the law enforcement side, but again, right now, conversations are probably the extent of it.
Great, thanks so much. And what about, I know again it's early on in Rhode Island, but Debbie and Deb, anything that you would add to that?
No, I would say it's super early. I think we were in a place where the accountable entities, and I bet a lot of states will experience this, we're pretty strongly saying we don't need partnerships at all, we've got this. And at the same time, we had community organizations saying, they really don't know how to do this. We do it better than they do. And so really we're kind of a few steps back from there, just saying, no, you've got to have some partnerships. You've got to do some things outside your four walls. And we're going to put some parameters on them, but not much to start, to encourage and to invest in, because we put some dollars on it, those partnerships, and not really be prescriptive about which ones. And it comes back to, you know, what we kept telling ourselves in the beginning. We don't know which ones matter the most, and it might be different for each AE. So we haven't really pushed one over another.
Great, thanks so much. A number of other questions came in, and I know we have a relatively large health plan audience, and Minnesota and Rhode Island, I know you both touched on this, but if you could just elaborate a little bit more on your expectations for the ways in which Medicaid managed care plans in your state would be helping to drive some of this addressing of social determinants of health, and maybe Matt, we'll start with you again.
Sure. So within the IHP program, you know, we do run it across both the Medicaid fee-for-service as well as the managed care population. And so the beneficiaries that are being managed under managed care are part of, say, the population-based payment, but we directly pay that, so we aren't even at this point expecting the MCOs to pay that out. It does mitigate or kind of impact some of the shared savings and losses, which I didn't get a chance to talk too much about, but I'll kind of move on from that. If people want to follow up, they can always reach out to me. I'd say it's more of some of the work that is happening at the MCOs and looking at addressing social determinants and some of the innovation that they're looking at. This is all really a fresh new area in many ways. I think some of us have been working this a lot longer than others, but applying it in this way to the health system is relatively new. And so really as an informant and as a partner in thinking about how to do this has been more of how our relationship with the MCOs has moved. Some of our MCOs have maybe some specific programs, pilot programs, those types of things that they're looking at these social determinants. So it's sort of more adjacent to the IHP than directly involved or impacting the IHP per se, if that makes sense.
Yep, it does. Great. Thank you so much. And then what about Debbie and Deb in Rhode Island?
So I would say for us it's a lot more centrally that the MCOs play a pretty substantial role. In fact, they are they're in a lot of ways the center of this program, because our program starts with our partnership with the MCOs, and all of the requirements for our ACO capacities are built into our managed care contracts. And so we're really relying on them as partners to implement the requirements of the AE program. And in doing that, we've also established, so we set aside incentive dollars in part, the majority of which is going to the ACOs, but a piece of which is going to the MCOs specifically to ensure that they were providing the necessary supports to enable the AEs to succeed. And we've defined some of the capabilities that they have to provide. So they have to provide monthly claims level data, and they have to provide attribution rosters, and they have to provide very specific information to enable that partnership. And they also have to build a partnership in terms of having a shared management structure between the ACO and the MCO. And those requirements are we're still working through some of that. We haven't even got it out there publicly yet, but we're working through the expectation that this is a partnership and trying to make it so that the state doesn't, again, define the program, and at least set the guardrails and the requirements, and the MCO and the ACO together decide what they do well and which pieces each of them manages.
Wonderful. Thank you so much. So we think there's time for one final wrap-up question, and I almost hate to ask this because I know that Minnesota and Rhode Island are already so innovative, but there are a lot of questions around kind of what's next for you guys. So Matt, maybe again we can start with you about sort of where you think all of this is going next, and we had a couple questions specifically probing at whether anybody was planning to take this to sort of broader accountability at the kind of geographic level.
So I think this is the question, and I think it's the one that we kind of have in our mind at all times as we're working on this, is what is the next step? We aren't at this point planning on moving to more of a geographic sort of accountability per se, but what we are trying to do is look at, we're right now really limited in our social risk factors, for example, to data that we have, and that's pretty limiting, and that also misses some really important pieces, and it's based on existing claim structures, existing enrollment structures, existing data collection structures that have some assumptions built into them that may not necessarily be accurate. For example, the cost assessment that we do for evaluating social risk is still based on medical cost, and so we're missing a huge portion of social cost and other factors. And so I think we're interested in continuing to move in those directions of really capturing some of the harder to capture pieces, some of the maybe burdens that are seen at the provider level and especially at the beneficiary and person level that we just don't have a good view of right now. And so that's really where our sort of next steps and conversations have been with different groups. Moving towards more of a geographic, I think it's something that maybe is on the horizon, but pretty far down, if at all at this point.
Great, thanks. And Debbie and Deb, any final thoughts from your end?
I would say it's in two directions. One is we're still on the, Minnesota's on phase, what do they call it, 2.0. We're just hitting 1.0, and so we know there's a lot of places where we have to do more. to enhance the program. We have to move to risk. That's our critical next step. We have to build in some risk adjustment capabilities because right now we don't have that. And we have to learn from this initial tracking we're doing on the social determinants to be more specific about our expectations for the types of capabilities we want. That's within the program. We're also trying to build the one population that's not in our program right now is the LTSS population. It's not in our core managed care program, therefore it's not in the core AE program. And if we look at addressing the needs of high-risk, high-cost populations, and we don't address LTSS, we're really missing a big piece of the challenge in the population that needs better care coordination, where we need to do better. And so that's a place that we're calling our specialized AE pathway that we're trying to build while we're also moving forward with our core program.
Great, thank you so much. Well, that takes us to the end of the webinar today. We wanted to say a huge thank you to all the call attendees for joining us. A big thanks, especially to the panelists for their great presentations. And thanks again to the Commonwealth Fund for funding this work. If we could please remind everybody to please take a moment to complete the survey at the end and to let us know, especially if there are additional topics you'd like us to cover. And just as a final note, we received so many great questions that we unfortunately didn't have time to cover today, but we will plan to pull something together that we will be posting on our website, so stay tuned. Thanks so much, everybody, and enjoy the rest of your day.